from the College of Speech Therapists and also an MBE for her services to speech therapy. Pam opened one of the first speech therapy research units in Bristol in 1995, and since coming to Sheffield she has held positions of Dean of Faculty for the Medical School. She's been 3 years as Clinical Director for the South Yorkshire Comprehensive Local Research Network and has also been Chair of the Sheffield Health Watch.
Thank you very much indeed. Thank you for the invitation to come and speak to you. I'm going to turn things slightly round. You will see that the topic I was given was regarding speech and language therapy. I'm going to cross that out, which would be great if I could. It's not working. Ah, there we are. I've crossed it out. I was pushing the wrong button. And I'm going to talk about integrating research into practice just generally. But I'm also going to turn something else on its head. The reason I got into research was because I was a practitioner and I wanted to be a better practitioner. And there will be a lot of people here who actually their involvement in research is driven because they want to be better clinicians. And that's an important career ambition. And it's as important as having the ambition to be an academic professional. So there are certain things that I'd like to sort of change round. Risk comes from not knowing what we're doing. And there's an awful lot of things that we don't know. But allied health professionals are not alone in feeling paranoid. Every single profession is paranoid because there's only a small amount of what we do which is evidence-based. 3 years ago, there was a BMJ article which had looked at what percentage of interventions by GPs were evidence-based. I'd like you to shout out what percentage you think they thought. This is 3 years ago. 5%. Okay, we've got a bid for 5%. 40%? You're dead on it. You must have read the article. Well done, Gail. It's 10% of what GPs do is informed by evidence. And there's an awful lot, like everything we do, that is a bit of evidence, but it has to be translated because of the practicalities or because of the blend of issues that patients have. But that shouldn't stop us trying next year to do 11% and 12%. And that hopefully is the way we go. But even erudite surgical procedures, a lot of it is, well, I haven't seen this one before, but I tried something like that, and I've read that, I'm going to have to adapt it, because that's the real world. And so we need to be very aware of what we don't know and be able to focus on that. Now, the ingredient word in the title of my talk was made me think of the Great British Bake Off, you know, because I'm very academic. And I was looking at how do other areas know whether they're doing well or not. So in the Michelin star, you can actually see which ones are rated highly, and you can go to a part of the country and look at which of the Michelin star services, restaurants, whatever, and go to those. But there's also the NHS Atlas of Variation. And the thing that is striking about both of those sort of quality assurance digests is that there is variation. There is tremendous variation. In this country, we have variation in the numbers of people who survive colorectal surgery. Now, what's interesting about that, it isn't that we've just got some bad surgeons in some places. We may have. But it's also to do with the demography that affects the way that people react with their conditions, or affects whether they're going to go see their GP early or late in their condition. So there are lots of factors. In the Michelin star, some people, some restaurateurs can get fresh fish really easily. If you're in Sheffield, it's a bit of a plod to the sea. So it's all those sort of things really affect the variation in practice. But we can learn incredible amount by looking at variation. And that's really where clinicians can come in. It's having that hunger of, what are they doing down the road? Is it slightly better or slightly worse? Would you know whether you are the best in your profession at the moment working with a certain condition? I certainly wouldn't, because I can't compare myself with others. Would you know whether the last 2 sessions of your therapy was worth the £150 that those 2 sessions would have cost the NHS? Would the person really benefit from that? A grade 6 therapist on the agenda for change will cost the NHS around about £70. Would the patient, if they were given £70, be happy with that, or would they prefer to go to a spa? And would they get just as much? There's a lot of things that we really don't know that as clinicians we should be looking at and helping researchers to ask the right questions. Nearly all of us, perhaps in this room, will think that we're part of either enablement or rehabilitation. And that is not only helping people to overcome their conditions, but to perhaps manage them from a psychological perspective and a social perspective. And I really like those definitions because it shows the mixture of what we're trying to achieve with individuals. And research has answered some questions for some groups and other questions for other groups in different professions. And that's why working together as allied health professionals, we can really foster that exchange of information in many different ways. But we need to know the essentials. And going back to the bake-off theme, it's always useful to really know the basics. And as we get a bit further away from our training, as we mature, it may well be that we do not know the recipe as is current. And there is some suggestion that the younger practitioners are actually more knowledgeable with regards to the active features of their therapy than the more mature individuals. But the more mature individuals have experience, which can be a two-edged sword. So what are the principles of therapy that we're trying to achieve? Usually, whatever profession we're in, we're trying to identify or diagnose the disorder. And that in most of the professions is where research has really changed our understanding. 15 years ago, it was not recognised how many different types of dementia there are. Now there is much more understanding of the types of dementia. We did not know the types of cerebral palsy there are. Now we do. So an awful lot of research has helped us to disaggregate these populations. Not surprisingly, when I was doing research on aphasia 30 years ago, we came out with very equivocal results because we were just saying anybody with aphasia can go in this trial. Now you select certain types of aphasia, certain types of dysarthria, certain types of balance disorders for your trials because we know more accurately how to disaggregate these large populations. You see that in cancer trials. Treatments have become much more specific since people have been able to really disaggregate and not just say it's a cancer, it's a malignant tumour, but what type, where, what are the genetics of it, and you can tune it in that way. So really research has driven us into the next area, which should help us to target our efforts on restoring function and strategies for that. Because the types of strategies appropriate for one dementia, one cerebral palsy, one musculoskeletal problem is going to be very different from different people within that overarching group. So it helps us in that way. But we aren't quite so far along the research route to really look at the evidence for some of the interventions that we are undertaking. And that's really the effort of allied health professions. Now, this morning on Radio 4, you probably heard that there's a tremendous strength and ambition to cure cancer by tailoring the drugs to the genetic makeup of the autoimmune system of people with certain cancers. So there will be one drug for one person. Now, it's very possible that in the future, and it may be 20 years ahead, but we should be working towards it, that certain approaches will work for certain people with certain conditions in certain environments. And that these large randomized controlled trials really will show fairly equivocal results until we can get that tailoring. Now, as allied health professions, you tailor already. You know when to push somebody, when to encourage them, when to back off, because you are reading the character as well as the problem. You are seeing what bits seem to work with an individual. So you've already got the feel of that, but we haven't necessarily got the objective evidence of that. We have to look at the ways of helping people to use their remaining abilities and being able to target those, such as improving communication through different devices, etc., and improving social participation. We all need to know about the best ways of encouraging and assisting people. And a lot of our work could be better informed if we knew people's characters. You and I know that after about 10 minutes with someone, you've got an edge of what their character might be like, and you know where not to go fairly quickly with a lot of patients or their relatives. And you will target that. A colleague of mine who did her PhD looked at personality testing before the person had their hip replaced. And what was interesting is that the personality was associated very strongly with the day that the first steps were made. And those which were more extrovert and very risk-happy were much better at getting on their feet quicker. Those that were more diffident took longer to get on their feet. You probably sense that already and try to cope with that. But there are so many different environments where perhaps knowing the personality and being able to adapt it and the therapy to match could be made more explicit. So how can we improve our therapy, which is why I got into research and why I stay in research and feel passionately about it. I'm not passionate about counting the numbers of hairs on the top of a pin. I know colleagues that are, but I'm not. Because I think, and the reason I wear my brooch of the question mark, is that virtually every day in clinical practice, there's something that you don't know. And sometimes you think you know something, and then, blow me, you find you don't. And that's very salutary. So you can learn from research. Now I'm going to stop my monotonous voice at this point and ask you to do something very quietly on your own. I want everybody in this room to write down one piece of research that they've read in the last 12 months that made them do something different in their job. That includes researchers and includes managers, and there's nobody in this room that can be excluded from this activity. Can you think of one piece of research that made you do something different in your job? If you can't think of something, write down your shopping list, because everybody else thinks you're really clever. I've done this over the last month or so with many different groups, and around about 3% of the individuals that I've been talking to have been able to say, I've changed something I do in my job because of that research that I read. And that is really quite depressing, because there are an awful lot of people who spend their time doing research. How many journals are there that publish research in the English language pertinent to AHPs? There's around about 75. They're all published at more than twice a year. All of them have more than 6 or 7 research papers in them. All that research, all that money, and we're not reaching out to say, I ought to be changing something, I should be doing something differently. And one thing that I'd love to be adopted in the NHS is in staff appraisals, there was a question of, what have you changed in your job based on research? And that should happen in admin, in clinical practice, in everything, because there's research in all of these areas. And we should be hungry to change. We become too comfortable doing the research we've always done. The thing that I took as a challenge, I thought, I've always tried to say, okay, what am I going to change? And I've had a real anti about conversational analysis. God, it sticks in my throat, you know, counting these bloody words and interactions. And I thought, well, I don't like it because probably I don't know much about it. There's a possibility. So I read it, and actually it's quite interesting. And what's more, I think it's of value. You know, this was a sea change. A sea change. I'm not entirely happy that I'm going to adopt it just yet, but I will be happy to read and review an article that's got CA in it, whereas before, as soon as I saw that phrase, I thought, oh, I'm not going to getting into that. And we all should be looking at, what are we uncomfortable? Are we uncomfortable because we don't know, or it looks like a fiddle, or it means I've got to give up something that I used to do very comfortably? And so next year, or this 12 months, I'm looking at response shift. As a, you know, am I going to adopt response shift? I need to read more about it. I'm almost sort of getting quite warm about it at the moment, which is a worry. So I'm trying to put up my defences while I read. But learning from research is something that keeps us fresh, keeps us looking at how we can keep our research, clinical practice appropriate. But the last two, and how we can improve our clinical work, is data collection and comparison. Going back to the Michelin star, those people who have been not rated this year will be looking at the restaurants that got rated and what did they do to get the star rating. If we can look at other services and see what are they doing that's better, is it because they've reduced the gradings of posts in our area as compared to their area? Is it because they see people earlier, later? What is it that makes it different? Comparison and data collection is really helpful in many ways. I mentioned that experience is a double-edged sword. Experience is a double-edged sword in that it can lead us to be very passive deliverers of care because we're comfortable with it. We don't necessarily show shock and horror when somebody comes up with a blend of difficulties. But it also has the ability to sometimes we might be able to rescue a situation by having had experiences in the past. So that if somebody's got a unique combination of difficulties or does something slightly different, always remember the time when patient I was seeing who's had a laryngectomy suddenly started to bleed from his tracheostomy with a lot of volume. Now, I was experienced enough not to show shock and horror, and I was experienced enough to know that my carpet was fairly new in the clinic room and I wouldn't get another one for 5 years, so that I got the metal waste bin, was able to catch the blood before it went on the carpet. And I was experienced enough to know that this was not a usual symptom of getting esophageal voice, and therefore trying to get assistance was quite good, quite useful. The student was saying, do they always do this? Do they always do this? And I knew that they didn't always do that. And so I said, well, sometimes it happens, so as not to panic the patient. But meanwhile, kicking her to go and get help. So it sometimes helps, that sort of rescue sort of situation. Thanks. What makes therapy more successful? We know, looking at the research across our professions, that timing of therapy, when you start therapy, will have an effect upon its success. We know that nearly always, and all research, whether it's physio, OT or whatever, involving other people in the care seems to be positive, have a positive impact. We know that there is differences with regard to the lengths of treatment. Some pieces of work show that short, brief interventions are as good as long interventions. Others say that long interventions are better than brief interventions. Intensity, there is more consensus that the more intensive you provide intervention, the more effective it is. But that's not for every client group. And technology seems to be having a very interesting impression on the way we deliver therapy, and we will have to watch this space to see how that bears out in the future. So what is expected? The signature bake. Each baker or allied health professional will create their own signature version of what the evidence is and combine it into something that they feel acceptable to the judges or the recipients of our care. The technical bake is very often where we are, in that we know part of it, but not entirely all of it, and we try to put it together in a way, using theory to underpin what we do. But theory is changing all the time, and so keeping up to date with that helps us to be technically good. And that's really an important aspect. Not just going on our fantastic interpersonal skills, but knowing the technical necessities of our interventions. And the showstopper, our specialty area, where we can really show off because we're top of the tree with treating something obscure brilliantly. So hopefully, the signature bake is based on evidence. And the technical bake is based on the evidence, but adapted with our knowledge of theory. And the showstopper is when we're blending research, techniques, our interpersonal skills, with the knowledge of what is needed at that time. So we need to be creative, based on knowledge, not too inventive that we go away from theory and underlying principles. We need to know when we don't know and when we're experimenting. And sometimes we're not very clear about that ourselves. Problems with integrating research, and I've just got a couple of minutes and I'm going to then skip on. There are essentially different populations that I have in a research trial to those that you see in the clinic. In a research trial, we have people who have aphasia of a specific type, have good hearing and monolingual and no confusion. In the clinic, you have people who have got a bit of dysphasia, possibly a bit of cognitive decline, don't want to be there, multilingual and as deaf as a post. So very different populations. There's a lack of linearity, really looking at the course of the patient over the time. And of course, our interventions are complex and not always precise as in a research project. But that doesn't mean that research can't help us to adapt in those ways. Research polarizes the biomedical and the psychosocial, and in this room there will be people who are much more biomedical and people who are much more on the psychosocial. And we need in allied health to be able to blend those together. And we need to actually make sure that the evidence of some services are also matched with services that have other aims and objectives. So those that are medical can be matched by those that will provide support and assistance to individuals. Now I'm going to, oh gosh, I've got through a whole talk without mentioning TOMS. This is a terrible blow to me. And coming on to therapy outcome measures has tried to address some of these issues, because what we've tried to do is say that every single clinician should gather data, big data, that will help us to compare services and to highlight differences between services to inform research questions. Now, I'm sorry that my last slide is so technically and scientifically challenging, but you will possibly say that knicker size is not related to global warming. You might be a person who says that it's entire proof of global warming. What we know is that knickers got smaller up until Bridget Jones's diary, when they got bigger, so I had to finish off my washing line at that point, because my argument was destroyed with Bridget Jones. The world got warmer over that period of time. We know there's an association. We don't know that it's causal. So every single clinician, if they could collect data, you will know there's an association with what they're doing, but you won't know it's causal until that's passed into a randomized controlled trial. But you need to look at the associations that will generate the questions, and then the researchers can take it from there. So every person in this room, manager, clinician, or researcher, can foster research, improve their practice with research, and feed into research. Thank you very much.
Thank you, Pam, for a fascinating and thought-provoking talk, particularly the cakes and knickers. Any questions for Pam?
goodness. I could do a workshop on this, but let's cut it down to two minutes. It's very important to not wait for the perfect measure, because we will never get the perfect measure. You always want a measure that's trying to capture the difference that you're trying to make in a patient. So in dietetics, you might be wanting to change the actual disorder itself, the obesity or the blood sugar levels or whatever. But in addition, you will want that person to actually be able to function better. So you might be doing advice on getting them to be more active, going out more, etc. You might actually be encouraging them to do more social participation, to be more confident despite their difficulty, be able to control their difficulty in whatever way, and perhaps something on well-being. And so the TOMS actually gathers data on those 4 areas. It's possible that with some clients you will be labouring on one aspect and not others. In other clients you might be labouring on all. But you need to identify what are you trying to do, what do they like now, then your magic, and what are they like then. Now, in certain professions, they're gathering that data nationally. And that allows us to see those services that are very biomedical and doing fantastic things on impairment, reducing the blood sugar levels, reducing the obesity, but those people might be as miserable as sin. Another place might have fantastic psychosocial support for people who are obese, happy little bunch there, but they're still rather obese and have got high blood sugar levels. So we have to actually look at the whole of that and be able to see what are we providing and what is the impact of that. That's Thomas in about 2 minutes.
Okay. One final quick question from anyone?
Tony Redden again from Leeds. I had a question related to, you had an observation about intensity, and there's often a misfit between the intensity of the intervention that's used in randomised controlled trials in perfect circumstances, and then what we're allowed to do in the NHS where you only have 2 visits in an episode of care. Do you have any perspective on how you manage that?
I think it's getting the strength of that evidence, because sometimes the evidence is such that if you give such a small dose, it isn't worth, it's a waste of public money. And it's just a pretense of providing speech therapy or physio or whatever. And it would be more honest to the community at large if one said, no, providing 3 sessions isn't enough, let's save the money. There are other places where the intervention is given in a sort of fairly ad hoc way, and it might be provided more than is required because there hasn't been the handing over to self-management or to other support agencies. So it's really looking at what does the research show us, how strong is that evidence, and let's be bold. If just that we're providing therapy to tick a box to say we've got physio, OT, drama therapy, radiotherapy or whatever, radiotherapy probably wouldn't have an effect on, because that is very precise. But all these other therapies, if we can actually say, no, there's no evidence for that, don't pretend, let's put all that money into something where we know more effort will make a difference. But it would be a bold man. You're the man for it.
Thank you, Kat.
Thank you.